Hi, my name is Nguyen. Today I would like to do the case presentation for adult gerontology and adolescent cause chief complaint and SBI. So Emily is 14 years old, Vietnamese female. She came to clinic today to complain about the irregular menses, hormones irregular. She haven't had a period from May to October 2025. Last period was November 1st, 2025. She have a moderate pain, cramping occur first 1 to 2 days of flow. She have been using the Tylenol for pain and cramping. She have no pertinent past medical history, no pertinent past surgical history. Her mother have a hypertension and asthma. Her father have a no problem. Social history. She lived with mom, dad, sister, and brother. She in the night rate at Tacot High School. She reported she drank cupcake or snack portion and sweet tooth fruit. She joined team cheer team. She denied on drug. She like boy and have a boyfriend once. She denied any current or past sexual activity. Sometimes she feel down and she have a friend to talk and she talk to her mom too. She deny any suicide. No ideation or homicidal ideation. She taking Tylenol 500 milligram, one tablet at needed for cramp. She have a no allergy, physical exam finding. She have heart rate 94, respiration rate 20, temperature 97.7, oxygen saturation in 97%, weight 99.2, height 164 centimeter, BMI 36.9. She alert and oriented in no acute distress. She normal gait, lip muscular, tongue normal, teeth and gum normal, thorax wide, pupil equal and reactive, her ear normal but laterally, her neck no adenopathy, supple symmetrical, trachea midline, and thyroid no enlarged, symmetric no tenderness, mass nodule, lung is clear to auscultation bilaterally, the heart regular rhythm with normal rate without murmur, abdomen soft, non-tender, bowel sound normal, no masses, no organomegaly. She have a normal external genitalian, no eryma, no discharge, tender state, four extremity, normal, warm and wearable, no cyanosis, clump, clumping, edema, neuro normal without focal finding, um, mental status, speed normal, alert and oriented time 3, and relax is normal and symmetric. For diagnostic, I order the CBC, FHN, testosterone, total LH, prolactin, A1C, lipid panel for her. Um, Differential diagnosis include the pregnancy, um, pituitary tumor, hyperprolactin, anemia, PCOS, early menopause, uterine pathology condition, thyroid dysfunction, transient anemia. Transient amenorrhea may occur in first to post-menstrual year or after discontinuation of the oral contraceptive and in the woman who receive the Depo-Provera. Obesity-related disorder, idiopathic disorder, hyperandrogenesis, and amenorrhea may be caused by obesity, Cushing syndrome, hyperprolactinemia, thyroid disease, adrenal disease, hypergonadotrophic amenorrhea caused by Turner syndrome, Lafferty syndrome, chemotherapy, autoimmunity, hypogonadotrophic amenorrhea as a result of emotional and physical stress, depression, nutrition deficiency, weight loss, eating disorder, thyroid and adrenal dysfunction, isolated gonadotrophin deficiency, hypothalamic and pituitary lesion infection. Final diagnosis. So I will use the Rotterdam criteria to diagnose for the patient. The Rotterdam criteria require the presence of two of the following to diagnose the PCOS. First, the clinical biochemistry hyperandrogenism. Secondly, ovulatory dysfunction, and the third is polycystic ovaries on ultrasound, and the patient have a elevated total testosterone and irregular menstrual periods. So that she have a diagnosis with the PCOS. Clinical decision making. Because she have a high BMI, so she need to do the lifestyle modification, include exercise and diet to lose weight, because obesity can cause the insulin resistance and hyperinsulinemia, which promote the ovarian androgen production. And she also can use the combined oral contraceptive pill to regulate the menstrual cycle and reduce the endometrial hyperplasia risk, lower androgen level. Moreover, she can use the metformin to improve the insulin sensitivity and reduce the risk of develop the diabetes type 2 and metabolic syndrome. Um, she should be screened for anxiety and depression with the BHQ9 and GAD7, because the PCOS is linked to increased anxiety and depression. Early screening and support can prevent the escalation. Leadership in care delivery. The intervention should be referred to dietitian and encourage moderate physical activity, 150 minutes weekly, and behavioral counseling if needed for the PCOS-related body image, distress and anxiety. Dermatology for persistent are needed, following 3 months to assess the effectiveness of the treatment plan regarding weight loss, mental health, referral, and returning the menses. Um, Demonstrate an autonomy in clinical decision by develop the initial diagnosis and treatment plan, follow the evidence-based guideline. I use a 2023 International Evidence-Based Guideline for assessment and management of the PCOS in this case. Um, and I also select medication resume and made the dosage adjustment on the case. On this case, I ordered the appropriate lab like A1C, lipid panel, testosterone, the LH, FSH and interpreted the result, educate the patient about the nature of the PCOS and empower her to self-management through risk analysis, physiolog- physiological risk factor. She have a BMI 96.9, so she have obesity and high risk for insulin resistant, which cause the hyperinsulinemia. Hyperinsulinemia cause the increase in the androgen secretion by T cell and inhibition of the production of sex hormone binding globulin in the liver, thereby increase the circulating concentration of the bioactive free testosterone. Hyperandrogenism is further aggravated by the hyperinsulinemia. So treatment for her is order fasting, insulin, glucose, and lipid panel to assess the metabolic risk, lifestyle intervention to lose weight, metformin for the patient with elevated insulin and impair the glucose tolerance, COC to manage irregular menstruation and androgen symptoms, um, risk analysis for the psychological risk factor. So depressed, anxiety, and eating disorder is associated with the PCOS. Um, so I administer the mental health screening tool like PH Q9 GAD7, refer her to the mental health services for the CBT and body image counseling to the regular lifestyle goal instead of weight-centric messaging. Risk analysis and environmental social risk factor like sedentary lifestyle, diet high in processed carbs and sugar, limit access to healthy food and exercise option. Um, and treatment plan include uh, referral to the dietitian with the cultural appropriate, realistic nutrition plan, cooperate with the social worker to assist to access to low-cost medication and transportation for appointment, engage the family in lifestyle planning to increase the home support, offer telehealth option to follow up due to transportation barrier, evidence-based practice. 2023 International Evidence-Based Guideline for Assessment and Management of the PCOS is applying this case. This guideline is led by Monash University, European Society of the Human Reproduction and Embryology, American Association of American Society for Reproductive Medication and over 200 international experts. This is most current and comprehensive guideline and reflect the latest global consensus of PCOS. It's mentioned about the hair remotion, like lifestyle modification, refer to dietitian, encourage and moderate physical activity, behavioral counseling if needed for PCOS-related body image distress and anxiety, metabolic and cardiovascular risk screening, so she should be assessed for cardiovascular disease risk, lipid panel, impaired glucose tolerance, and type 2 diabetes risk symptom of obstructive sleep apnea. Mental health screening and support should be included in the treatment plan. Ethical reflection, there are some challenges. In this case, her model existed on pelvic ultrasound to confirm the PCOS. The patient is minor and needs support from the parent. The parent have a low health literacy and parent fear of the infertility. Ethical principle that guide the decision. First, non-maleficent. According to the 2023 International Evidence-Based Guideline for the PCOS, state that the pelvic ultrasound and AMH should not be used for diagnosis of in adolescent due to the high false positive in the pubertal development. So uh, we should avoid the potential unnecessary and invasive tests that could cause the anxiety and misdiagnosis. Regarding to autonomy, provide clear age-appropriate education to both adolescent and her parent about the rationale behind avoiding ultrasound at her age. PCOS and treatment, including the parent support in the treatment plan, provide the facts-based fertility education and reassure that the CPOS does not always lead to infertility. Um, Beneficent focus on using appropriate diagnostic tool to minimize the harm and provide evidence-based care, referring to the 2023 international guideline and provide psychosocial support. Just to provide the resources to manage the PCOS, encourage patient parent to contact office for any concern that ensure that parent patient to have access to care regardless the health literacy barrier. Um, Health policy, there are limited insurance coverage that did not include the mental health services and nutrition counseling, both of which are recommended in evidence-based of the PCOS care. So respond, I saw out community-based program and offering the sliding scale and free counseling and nutritional services provided in clinic free style, lifestyle counseling and educational handout as interim solution. Opportunity use the existing public health guidelines to support routine screening for diabetes type 2, the hypertension, depression. These services were covered as a part of preventive care benefit under her insurance plan. As a result, facilitated early detection and intervention that for coexistent condition reinforce a whole person approach aligned with the population health initiative. Advocacy, um, limited income and uninsured. Um, I connect the I connect the patient to the community health center for low cost nutrition and behavioral support. Regarding transportation difficulty, um, we can schedule the telehealth follow-up visit and coronary appointment at the same day to reduce the travel. The care coordination, like streamline the referral to endocrinologists and dermatology, use the e-consult form to minimize the wait time and in-person visit. Medication access, explore the generic alternative, pharmacy discount, and the patient assistance program for oral contraceptive education, empower patients with evidence-based resources about the PCOS and self-managed strategy tailored with her health literacy level, the health portal registration for direct communication and appointment scheduling, advocate within the care team to ensure that her primary concern, including the appearance, mood, cycle regulation, were addressed early and respectfully. How this case helped to role as a non-practitioner student, so I can apply the complex evidence-based guideline within the new context of adolescent development. I have a chance to exercise the clinical restraint, especially when the family requests the pelvic ultrasound, which I know it could be appropriate at this age based on the 2023 International PCOS guideline. I educate both parent and patient in an appropriate and a cultural sensitive way to build a trust and understanding. Uh, it's reinforced the importance of developmental appropriate care and taught me to communicate the diagnosis in the way that support the autonomy while reduce the stigma around the body image, menstrual irregularity, and fertility concern. Program outcome. Um, Evidence-based practice, I apply the international PCOS guideline to make the age-specific guideline concordant decision. No ultrasound, clinical clarity only, clinical adjustment, parent hormone symptom management with psychosocial need, select appropriate lab, and avoiding the overstating patient centered care, honor the adolescent voice, ensure that she was heard, independent from her parents, and arrest her concern with the empathy and respect, professional collaboration, coordinate with the primary care, behavioral health, and dietitian support despite the insurance limitation, advocacy and the health policy awareness, navigate the health insurance limitation by finding low-cost community resource and telehealth mental health option, professional communication, uh, translate the complex endocrine and reproductive concept to developmentally appropriate language for both teen and parent. Impact on the future clinical practice. Educate and clean on the guideline that protect the patient from unnecessary procedure, perform the patient centered care, coordinate with the care team such as the dietitian and behavioral counselor and to support the patient, become a stronger advocate for equity, advocate for underserved population and integrate social determinant of health into every treatment plan, communicate with confidence and compassion, more confident in explanation complex topics like hormonal imbalance, insulin resistance, and long-term risk in a way that empower the patient to take ownership of their health. This is the references, and thank you for listening.